Welcome to our detailed exploration of the bones of the forearm and hand. In this video, we'll journey through the anatomy of the radius and ulna, the carpal bones, and the metacarpals, understanding their structure, attachments, ossification, and clinical significance. Whether you're a student of medicine, physiotherapy, or just curious about human anatomy, this guide will help you visualize and remember the key features of these essential bones. Let's begin by setting the stage with an overview of the forearm and hand, highlighting their importance in movement, dexterity, and daily function. Start with the transverse section of the radius and ulna. These two bones run parallel in the forearm, with the radius on the lateral thumb side and the ulna on the medial little finger side. In cross-section, you can appreciate their distinct shapes and how they relate to each other. The interosseous membrane connects them along their lengths, providing stability and serving as an attachment for muscles. This arrangement allows for the unique movements of pronation and supination, enabling the palm to turn up or down. Understanding this relationship is crucial for grasping forearm mechanics. Examining the inferior surfaces of the radius and ulna reveals their roles in forming the wrist joint. The radius features a triangular area for the scaphoid bone and a quadrangular area for the lunate bone, both crucial for wrist articulation. The ulna, meanwhile, ends in a rounded head and a pointed styloid process. These surfaces are not only important for joint movement but also serve as landmarks for clinical examination, such as palpating the radial pulse or assessing wrist injuries. The close relationship between these bones and the carpal bones sets the foundation for hand mobility. Radius has several important surfaces and landmarks. The posterior surface presents 4 grooves for extensor tendons, with the dorsal tubercle of Lister as a notable feature. The medial surface houses the ulnar notch, accommodating the head of the ulna. Laterally, the styloid process projects downward, serving as an attachment point for ligaments. The inferior surface, with its areas for the scaphoid and lunate, is vital for wrist articulation. These anatomical details are essential for understanding both normal function and the impact of injuries such as fractures. Several muscles attach to the radius, each contributing to forearm and hand movement. The biceps brachii inserts into the rough posterior part of the radial tuberosity, while the supinator attaches to the upper lateral surface. The pronator teres finds its insertion in the middle of the lateral surface, and the brachyradialis attaches just above the styloid process. These attachments enable flexion, extension, pronation, and supination of the forearm. Understanding these relationships is crucial for diagnosing muscle injuries and planning rehabilitation. The interior aspect of the radius, several key muscles and structures are attached. The flexor digitorum superficialis originates from the interior oblique line and upper anterior border, while the flexor pollicis longus arises from the upper 2/3 of the interior surface. The pronator quadratus is inserted into the lower part of the interior surface, playing a role in pronation. The radial artery, palpable for the radial pulse, runs medial to the sharp anterior border. These features are important for both anatomical understanding and clinical practice. Posterior aspect of the radius and ulna is characterized by several grooves that accommodate extensor tendons. The abductor pollicis longus and extensor pollicis brevis arise from the posterior surface, while the extensor retinaculum attaches to the lower anterior border. The arrangement of these grooves and compartments is crucial for the smooth movement of tendons during wrist and finger extension. Any disruption, such as inflammation or injury, can lead to functional impairment or pain. Several ligaments and membranes attach to the radius, contributing to joint stability. The quadrate ligament is attached to the medial part of the neck, while the oblique cord connects just below the radial tuberosity. The articular capsule of the wrist joint attaches to the interior and posterior margins of the inferior articular surface, and the articular disc of the inferior radioulnar joint is anchored to the lower border of the ulnar notch. The interosseous membrane, spanning most of the interosseous border, is vital for force transmission and stability. Lower ends of the radius and ulna are organized into 6 compartments under the extensor retinaculum, each guiding specific tendons. 4 compartments relate to the radius, the 5th is at the junction of radius and ulna, and the 6th is on the ulna itself. These compartments ensure that extensor tendons glide smoothly during wrist and finger movements. Understanding their arrangement is essential for diagnosing conditions like tenosynovitis or for surgical interventions involving the wrist. Radius ossifies from 3 centers: primary center for the shaft and secondary centers for the lower and upper ends. The shaft begins ossifying during the 8th week of development. The lower end, which is the growing end, ossifies from the 1st year and fuses at about 20 years. The upper end ossifies from the 4th year and fuses at 18 years. This pattern is important for understanding growth, development, and the timing of certain fractures in children and adolescents. Fractures of the radius are common, especially about 2 cm above its lower end, a site known as Carpal's fracture. This injury typically results from a fall on an outstretched hand, causing the distal fragment to be displaced upwards and backwards. The radial styloid process may shift proximally relative to the ulnar styloid process. If the distal fragment is displaced anteriorly, it's called Smith's fracture. Recognizing these patterns is crucial for proper diagnosis and treatment, as they affect wrist function and alignment. Sudden forceful pull on a child's hand can cause subluxation of the head of the radius, commonly known as a pulled elbow. This occurs when the head of the radius slips out from the angular ligament's grip. The child may present with pain and inability to move the elbow. The head of the radius can usually be felt in a hollow behind the lateral epicondyle of the humerus. Prompt recognition and gentle reduction are key to restoring normal function. Ulna is the medial bone of the forearm and is homologous with the fibula of the lower limb. It features an upper end with a hook-like olecranon, a shaft, and a lower end with a rounded head and styloid process. The upper end's concavity faces forward, and the styloid process lies posteromedial to the head. These features help determine the side of the bone and are essential for anatomical orientation during examination or surgery. Upper end of the ulna presents the olecranon and coronid processes, as well as the trochlear and radial notches. The olecranon projects upward, forming the point of the elbow, while the coronid process projects forward. The trochlear notch articulates with the humerus to form the elbow joint, and the radial notch accommodates the head of the radius for the superior radioulnar joint. These structures are vital for elbow stability and movement. Shaft of the ulna has 3 borders, interosseous lateral, anterior and posterior, and 3 surfaces, interior, medial, and posterior. The interosseous border is sharpest in the middle, providing attachment for the interosseous membrane. The interior border is thick and rounded, while the posterior border is subcutaneous and easily palpable. These features are important for muscle attachment and for identifying the ulna during clinical examination. Interior surface of the ulna lies between the interior and interosseous borders and contains a nutrient foramen for blood supply. The medial surface is between the interior and posterior borders, while the posterior surface is divided into 3 areas by 2 lines. These surfaces provide attachment points for various muscles and are important for understanding the functional anatomy of the forearm. Lower end of the ulna consists of the head and the styloid process. The head articulates with the ulnar notch of the radius to form the inferior radioulnar joint, while the styloid process projects downward from the posteromedial side. The groove between the head and styloid process accommodates the tendon of the extensor carpi ulnaris. These features are essential for wrist movement and stability. Several important muscles attach to the ulna. The triceps brachii inserts into the olecranon, while the brachialis attaches to the interior surface of the coronid process. The supinator arises from the supinator crest, and the flexor digitorum profundus originates from the interior and medial surfaces of the shaft. These attachments are crucial for elbow and wrist movements, as well as for the stability of the forearm. Ulna serves as an anchor for several ligaments and membranes. The interosseous membrane attaches to the interosseous border, while the oblique cord connects to the ulnar tuberosity. The capsular ligament of the elbow joint attaches to the margins of the trochlear notch, and the angular ligament secures the head of the radius. The ulnar collateral ligament of the wrist attaches to the styloid process, providing medial stability to the wrist. Ulna ossifies from a primary center for the shaft and secondary centers for the upper and lower ends. The shaft and most of the upper end begin ossifying during the 8th week of development. The superior part of the olecranon ossifies from a secondary center appearing around the 10th year and fusing by the 16th year. The lower end ossifies from the 5th year and joins the shaft by the 18th year. This sequence is important for understanding growth and the healing of fractures in children. The ulna is the stabilizing bone of the forearm, with its trochlear notch gripping the humerus. Fractures of the shaft may occur alone or with the radius, and cross-union must be avoided to preserve pronation and supination. Dislocation of the elbow, often from a fall on a flexed elbow, shifts the olecranon posteriorly. Fractures of the olecranon are common, while coronid process fractures are rare and usually accompany dislocation. Madelung's deformity involves dorsal subluxation of the lower ulna due to retarded growth of the radius. Long bones with epiphyses at both ends, the epiphysis that appears first is the last to fuse with the shaft. This means the growing end of the bone unites later. In the upper limb, the growing ends are at the shoulder and wrist joints. The direction of the nutrient foramen is typically opposite to the growing end. Understanding this law helps in interpreting growth patterns and predicting sites of potential growth disturbances or injuries. Metaphyses, located at the epiphyseal end of the diaphysis, is the actively growing part of the bone and has a rich blood supply. The relationship between the capsular attachment and the epiphyseal line is clinically important. If the epiphyseal line is within the joint capsule, joint infections can affect the metaphyses, especially in young individuals. This knowledge is crucial for understanding the spread of infections and planning surgical intervention. Carpus, or wrist, is made up of 8 carpal bones arranged in 2 rows. The proximal row includes the scaphoid, lunate, triquetral, and pisiform, while the distal row consists of the trapezium, trapezoid, capitate, and hamate. These bones form the foundation of the wrist and allow for a wide range of movements. Their arrangement and articulations are essential for hand function and flexibility. Each carpal bone has unique features for identification. The scaphoid is boat-shaped with a lateral tubercle, the lunate is crescent-shaped, the triquetral is pyramidal, and the pisiform is pea-shaped. The trapezium is quadrangular with a crest and groove. The trapezoid resembles a baby's shoe. The capitate is the largest with a rounded head, and the hamate has a distinctive hook. Recognizing these features is key for anatomical study and clinical practice. Proximal row of carpal bones is convex proximally and concave distally, while the distal row is convex proximally and flat distally. Each bone has 6 surfaces, with the palmar and dorsal surfaces generally non-articular. The dorsal surface is usually larger except in the lunate. These general points help in identifying the orientation inside of each carpal bone, which is essential for anatomical dissection and radiological interpretation. Scaphoid's tubercle is directed laterally, forward, and downward, while the lunate has a semilinear articular surface for the scaphoid on its lateral side and a quadrilateral surface for the triquetral on its medial side. These specific features are crucial for distinguishing between the carpal bones during anatomical study or when interpreting wrist X-rays. Triquetral has an oval facet for the pisiform on the distal palmar surface, and its medial and dorsal surfaces are continuous and non-articular. The pisiform, a sesamoid bone, has an oval facet for the triquetral on the proximal dorsal surface and a lateral surface grooved by the ulnar nerve. These features help in precise identification and understanding of wrist anatomy. Trapezium has a vertical groove for the flexor carpi radialis tendon and a sellar articular surface for the first metacarpal. The trapezoid's distal articular surface is larger, and its palmar surface extends laterally. The capitate is the largest carpal bone with a rounded head, while the hamate is wedge-shaped with a hook projecting from its palmar surface. These characteristics are essential for bone identification and understanding wrist mechanics. Carpal bones serve as attachment points for important ligaments and muscles. The tubercle of the scaphoid and the crest of the trapezium anchor the flexor retinaculum, while the pisiform gives attachment to the flexor carpi ulnaris and abductor digiti minimi. The hook of the hamate provides attachment for the flexor retinaculum and muscles of the hypothenar eminence. These attachments are vital for wrist stability and hand movement. Each carpal bone articulates with specific neighboring bones. For example, the scaphoid articulates with the radius, lunate, trapezium, trapezoid, and capitate. The lunate connects with the radius, scaphoid, capitate, hamate, and triquetral. Understanding these articulations is crucial for comprehending wrist movement and diagnosing joint injuries. Carpal bones ossify from single centers, with the timing of ossification varying for each bone. This process is important for assessing skeletal maturity in children and for diagnosing growth disorders. Radiographs of the wrist are often used to estimate bone age based on the appearance of carpal ossification centers. Fractures of the scaphoid are common, often resulting from a fall on an outstretched hand. Such fractures can lead to nonunion or a vascular necrosis due to disrupted blood supply. Dislocation of the lunate may cause carpal tunnel syndrome-like symptoms. Recognizing these injuries and their implications is vital for prompt and effective treatment, as they can significantly impact hand function. Hand contains 5 metacarpal bones numbered from lateral thumb to medial little finger. Each metacarpal has a head, shaft, and base. The head forms the knuckles, the shaft is concave on the palmar side, and the base is irregularly expanded. These bones provide the framework for the palm and are essential for gripping and manipulating objects. Metacarpals differ from metatarsals in several ways. Metacarpals have prismoid heads and shafts, uniform shaft thickness, and irregular bases. In contrast, metatarsals have flat heads and shafts, tapering shafts, and sharply cut bases. These differences reflect the distinct functions of the hand and foot, with the hand adapted for manipulation and the foot for weight bearing. First metacarpal is the shortest and stoutest, with a unique orientation allowing thumb opposition. The second has a grooved base, the third features a styloid process, the fourth has 2 lateral facets, and the fifth has a tubercle on its medial base. These features are important for identifying each bone and understanding their roles in hand movement. Determining the side of each metacarpal involves examining the shape and orientation of the base, shaft, and head. For example, the first metacarpal's anterolateral surface is larger, while the third styloid process is dorsolateral. These criteria are essential for anatomical study, surgical planning, and forensic identification. Metacarpals serve as attachment points for several muscles. The first metacarpal receives the opponens pollicis and abductor pollicis longus, while the second and third provide origins for the adductor pollicis and insertions for the flexor and extensor carpi radialis. The palmar and dorsal interossi muscles arise from the shafts, enabling fine finger movements and grip strength. Bases of the metacarpals articulate with the carpal bones and with each other. The first metacarpal forms a saddle joint with the trapezium, allowing thumb opposition. The second to fifth metacarpals articulate with various carpal bones and adjacent metacarpals, providing stability and flexibility to the hand. These articulations are crucial for the wide range of hand movements. Metacarpals ossify from a primary center in the shaft, appearing during the 9th week of development. Secondary centers appear at the head for the 2nd to 5th or base for the 1st during the 2nd to 3rd year and fuse with the shaft by 16-18 years. This process is important for assessing skeletal maturity and diagnosing growth abnormalities. Fractures of the metacarpals are common and can result from direct or indirect trauma. Bennett's fracture involves the base of the first metacarpal and impairs thumb opposition. Other metacarpals may fracture through the neck, often with forward or backward displacement. Recognizing these injuries and their mechanisms is essential for effective management and rehabilitation. Sesamoid bones are sometimes found at the metacarpophalangeal joints, most commonly on the lateral side of the thumb. These small bones develop within tendons and help reduce friction, protect tendons, and increase mechanical efficiency. Occasionally, extra sesamoid bones may be present at other joints, contributing to anatomical variation. Helpful mnemonic for remembering the order of carpal bones is, "She looks too pretty, try to catch her." This represents the scaphoid, lunate, triquetral, pisiform proximal row lateral to medial, and trapezium, trapezoid, capitate, hamate distal row. Mnemonics like this make it easier to recall complex anatomical arrangements during exams or clinical practice. Some important facts to remember: the radial pulse is felt near the lower end of the radius. The pisiform is a sesamoid bone in the flexor carpi ulnaris tendon. The first metacarpal is the shortest and strongest, allowing thumb opposition. The third metacarpal is the longest and serves as the axis for finger abduction and adduction. These clinical pearls are useful for both exams and patient care. Summary: the bones of the forearm and hand, radius, ulna, carpal bones, and metacarpals, form a complex and highly functional unit. Their unique structures, muscle attachments, ossification patterns, and clinical relevance are essential knowledge for anyone studying anatomy or working in healthcare. Understanding these bones not only aids in diagnosis and treatment, but also deepens appreciation for the intricacies of human movement. Thank you for joining this comprehensive review.